Welcome, curious minds, to the Deep Dive, where we journey into the complex microscopic worlds that profoundly shape our health. Have you ever considered how tiny organisms, often unseen and misunderstood, can have such massive, sometimes life-altering effects on human well-being?
It's truly astonishing, isn't it?
It really is. It's a field just brimming with surprising facts and critical insights. And today, well, we're going to pull back the curtain on some truly significant players.
Absolutely. These pathogens, though incredibly small, they really demand our full attention. Our mission today is to help you master this information, to truly understand these infections with the kind of depth and insight typically found among, the elite professionals in the field.
Exactly.
We're not just memorizing facts here, we're building a really comprehensive understanding of why these organisms matter in the broader context of public health and individual well-being, too.
Absolutely. Today we're embarking on an in-depth exploration of Chapter 157, Haemophilus and Moraxella infections, and we'll also be venturing into the intriguing HACEK group.
That's quite a lineup.
It is. We've distilled this complex medical information from authoritative texts, offering you, hopefully, a shortcut to being exceptionally well-informed. My goal is for you to walk away from this deep dive with a firm grasp of these challenging topics, understanding not just the what, but the why and the how. So let's jump right in.
Let's see.
Okay, so before we dive into our main stars today, Haemophilus and Moraxella, our sources offer a crucial, albeit brief, update on something everyone should know about: gonorrhea. Now, it might seem like a bit of an outlier here. Why is gonorrhea mentioned in this chapter?
Yeah, that's a really perceptive question, actually, and it highlights something quite important: the interconnectedness of, different bacterial pathogens and the ongoing efforts in vaccine development.
Okay.
What's fascinating here is that our sources connect gonorrhea to the broader landscape of vaccine research, particularly a licensed vaccine that offers a surprising degree of cross-protection.
Cross-protection against gonorrhea.
Exactly. So while Neisseria gonorrhea isn't directly related to Haemophilus or Moraxella taxonomically, the challenges in developing a gonorrhea vaccine and these unexpected discoveries, they provide really important contemporary context for how we approach bacterial pathogens in general,
Ah, I see.
It's about drawing lessons from one battle that might just inform another.
So it's about those broader lessons, applying that kind of professional mindset across different infectious disease challenges. Okay, so what are the key insights our sources give us on gonorrhea then, particularly for someone aiming for that professional level of understanding?
Right. Well, a fundamental aspect of managing gonorrhea, absolutely critical for preventing reinfection or relapse, is thorough partner management.
Partner management. Makes sense for an STI.
Absolutely. And the guidelines are quite specific. Any sex partners within 60 days of the patient's symptom onset or their diagnosis, they absolutely need to be treated.
60 days. That's a pretty wide window.
It is. And if the patient's last potential sexual exposure was actually more than 60 days before their symptoms or diagnosis, then the most recent partner should receive treatment.
Okay.
Our sources even point to something called partner-delivered medications or prescriptions. It's an option in states where it's allowed as a sort of proactive strategy to cut down those reinfection rates.
So the patient can take the meds directly to their partner.
Potentially, yes, or a prescription for them. And this is crucial for stopping further spread. Both the patient and their partners must abstain from sexual intercourse until therapy is fully completed and symptoms have completely resolved for everyone involved.
Right, that's key.
It's a holistic approach, really, recognizing that treating just the individual often isn't enough for an STI.
That definitely makes sense. It's a comprehensive approach, looking beyond just the person who walked into the clinic. What about prevention for the broader population, beyond treating current infections?
Yeah, prevention strategies really underscore the importance of, robust public health education, individual patient counseling, and behavior modification. There's a strong, consistent emphasis on condom use, naturally.
Naturally.
The recommendation is quite broad. Sexually active individuals, especially adolescents, should really be offered screening for STIs, even if they don't have any symptoms.
Proactive screening.
Exactly.
No.
For most male patients, screening can be done pretty efficiently through a nucleic acid amplification test, or NET, using either a urine sample or a urethral swab. These are highly sensitive and specific molecular tests.
Okay.
And importantly, there's a direct, critical link to HIV prevention. Preventing the spread of gonorrhea and other STIs can significantly help reduce HIV transmission.
How so?
Well, because genital ulceration caused by some STIs can compromise the skin's barrier function, essentially making it easier for HIV to enter the body. It's a potent reminder of how interconnected these public health challenges often are.
That connection to HIV really drives home the broader public health implications. Okay, so the big question. What's the status of a gonorrhea vaccine? It feels like we've been hearing about that possibility for a long time.
You're absolutely right. And the short answer is there is currently no effective, broadly available vaccine for gonorrhea. That remains a major ongoing challenge in public health.
Still no vaccine.
Not a dedicated one, no. However, there's significant progress being made. Several candidate vaccines are actually in field trials right now.
Okay, so there's hope on the horizon.
There is. And what's particularly fascinating and maybe a bit unexpected is an example mentioned in our sources concerning a licensed Group B meningococcal vaccine. It's known as Bexsero.
A meningitis vaccine.
Yes. In its prototype form, this vaccine, which was designed to protect against a completely different bacterium, Neisseria meningitidis Group B, showed a surprising reduction in gonorrhea incidence during a Group B meningococcal epidemic.
Wait, a meningitis vaccine reduced gonorrhea. How does that work?
It's thought to be due to shared antigenic similarities between Neisseria meningitis and Neisseria gonorrhoeae. They're related bacteria. So the immune response triggered by the meningitis vaccine offered some cross-protection. It's a compelling glimpse into the potential for these kinds of cross-protective vaccines.
That's genuinely fascinating. An unexpected bonus from a different vaccine. And you mentioned earlier a sort of bigger picture threat with gonorrhea.
Yes, and this leads to a critical long-term challenge. Our sources briefly highlight the emerging threat of untreatable gonococcal infection.
Untreatable.
That's the fear. This isn't just hypothetical. It's a stark reminder that antibiotic resistance is a looming global health crisis. As gonorrhea strains develop resistance to our current treatments, our therapeutic options just dwindle.
Like the antibiotics stop working.
Exactly. This makes those ongoing efforts in vaccine development, coupled with really robust prevention strategies, all the more critical for the future. We're potentially facing a return to, well, the pre-antibiotic era for certain infections. It's an ongoing battle that demands constant vigilance and, frankly, innovative solutions.
All right, let's pivot now to a bacterium whose name might sound familiar, but whose story, as you mentioned, is far more complex than just its initial mistaken identity. Haemophilus influenza. This is where I think the detective work in microbiology gets really interesting.
Absolutely. And the historical misnomer itself is, well, it's a fascinating little anecdote from the early days of microbiology, isn't it?
Yeah.
Haemophilus influenza was first recognized way back in 1892 by Richard Pfeiffer. And he, understandably at the time, erroneously concluded that this bacterium was the direct cause of influenza.
Ah, hence the name influenza.
Precisely. Of course, we now know influenza is caused by a virus. But the name Haemophilus influenza just stuck. It literally means blood-loving. That's the Haemophilus part. And influenza-like bacteria. It reflects its growth needs and that initial mix-up.
Little historical artifact in its name. So what are its basic characteristics? What does it actually look like under the microscope?
It's a small organism, typically measuring about 1 by 0.3 micrometers. It's a gram-negative bacterium, meaning it stains pink or red in a gram stain.
Okay.
What's particularly distinctive and sometimes makes it a bit tricky to spot is its variable shape. It's often described as a pleomorphic cuccobacillus.
Pleomorphic, meaning?
Meaning it can change its shape. It can appear as cocci, which are spherical, or bacilli, which are rod-shaped, or kind of anything in between, often like short rods or even threads. This shape-shifting ability can make it a bit elusive. And in clinical specimens, like, say, cerebrospinal fluid or sputum, it frequently stains only faintly with the counterstain, safranin, during gram staining, so it can be easily overlooked if you're not specifically looking for it or expecting it.
That definitely sounds like a challenge for the lab detectives. How does it grow? What does it need to thrive?
It's quite adaptable, actually. It can grow both aerobically with oxygen and anaerobically without oxygen. However, for aerobic growth, it has two very specific nutritional requirements. This is where the blood-loving name comes in again.
Ah, the X and V factors.
Exactly. It needs himin, which is called X factor, and nicotinamide adenine dinucleotide, or NAD, which is V factor. These factors are actually used in traditional phenotypic methods in the lab to help differentiate among Haemophilus species.
So these specific growth needs have practical diagnostic uses. But I think I heard a but coming. Limitations.
Yeah, well, these phenotypic methods, while useful historically, they do have limitations. The increasing availability of whole genome sequences from Haemophilus isolates, especially from the human respiratory tract, is revealing incredibly complex genetic relationships among these species.
So the genetics are more complicated than the growth factors suggest.
Much more complicated. It means that relying solely on growth factors for differentiation might not capture the full picture of their genetic diversity and their evolutionary relationships. It's a really dynamic field right now.
Interesting.
And just for context, H. influenza holds a really significant place in scientific history. It was, in fact, the very first free-living organism to have its entire genome sequenced. That was back in 1995.
Wow, the first one.
The first free-living one, yeah. A truly groundbreaking achievement that just opened the doors for understanding bacterial genetics at a level we've never seen before.
That's a major milestone. Okay, moving on to its classification. How are these strains categorized, and which ones are most clinically significant for us to really get a handle on?
Right. So H. influenza has 6 major serotypes, designated A through F. These are defined by their antigenically distinct polysaccharide capsules. Think of the capsules as unique outer coats that protect the bacterium.
Like different types of armor.
Kind of, yeah. However, you also have what are called non-typable strains. These are simply strains that lack a polysaccharide capsule altogether. They're naked, so to speak.
Okay, encapsulated versus non-typable. Which ones cause the most trouble?
Clinically, type B, commonly just called HIB, H-I-B, and the non-typable strains are by far the most relevant for human disease. While other encapsulated strains can cause disease sometimes, HIB and the non-typable strains are really the primary concerns globally.
Got it. HIB and non-typable.
And the type B capsule specifically is a linear polymer composed of something called ribosyl phosphate, or PRP. Heb strains primarily cause invasive disease, especially in infants and children under 6 years old.
Yeah, the non-typable ones.
Non-typable strains, on the other hand, are mainly mucosal pathogens. They thrive on the surfaces of our airways, think throat, lungs, though they can occasionally cause more invasive disease too.
So HEB's the classic pediatric invader, non-typables more focused on mucosal surfaces. Let's talk about how it spreads and the huge impact the vaccines have had.
Yeah, so H. influenza is an exclusively human pathogen. That means it only infects humans. It's not found naturally in other animals. That's a key epidemiological point.
Only humans.
Yeah.
How does it get around?
It spreads mainly by airborne droplets, like when someone coughs or sneezes, similar to a cold, or through direct contact with secretions or fomites contaminated surfaces.
Okay.
What's interesting is how colonization with non-typable H. influenza is a dynamic process in our upper respiratory tract. Individuals periodically acquire new strains while old ones get replaced. It's like a constant microbial turnover in your nose and throat.
A constantly changing neighborhood up there.
Yeah.
And then came the vaccine revolution. What effect did the HEB conjugate vaccines have? How did they change things?
Oh, the impact was profound. The widespread use of Hib conjugate vaccines in many industrialized countries led to truly striking, really unprecedented decreases in the rate of nasopharyngeal colonization by Hib.
So less of it hanging around in people's noses.
Exactly. And that, in turn, drastically reduced the incidence of Hib infection. To really grasp the scale of this public health triumph, just look at the numbers. The incidence rate per 100,000 among children under 5 plummeted from around 50 cases back in 1987 to fewer than 40 cases per year since 2000 in countries with widespread vaccination.
From 50 per 100,000 down to less than 40 total cases.
Per year, yes. It's an incredible success story. It basically reshaped pediatric infectious disease.
That's an absolutely stunning achievement. But what about globally? Is this success uniform everywhere?
Unfortunately, no. That's the catch. Worldwide, invasive Hib disease still predominantly affects unimmunized children or kids who haven't finished their primary immunization series.
So the vaccine isn't reaching everyone.
Not yet. While most World Health Organization member countries have introduced Hib conjugate vaccination, a large number of the world's children remain unimmunized. This is mainly in countries without well-established national vaccine programs or, frankly, adequate funding. It highlights a significant global health disparity, where the benefits of this highly effective vaccine just aren't universally realized yet. And furthermore, certain groups, like some Native American populations, have historically shown a higher incidence of invasive Hib disease.
Why is that?
Well, the factors are likely complex. It could include age at initial exposure to the bacterium, socioeconomic conditions, maybe even underlying genetic differences. The exact reasons are still being investigated. It's a multifaceted challenge.
Okay, so we understand its identity, how it spreads.
Hmm.
How does H. influenzae actually cause disease? What's the mechanism? How does it wreak havoc?
Right. Connecting this to pathogenicity. Hib strains, the encapsulated ones, cause systemic severe disease through invasion and then hematogenous spread.
Hematogenous spread
Ooh.
through the blood.
Exactly. The bacteria first invade the bloodstream, usually from the respiratory tract, overcoming local defenses. Then they travel through the blood to distant sites like the meninges, the membranes around the brain, and spinal cord or bones, and joints.
And the capsule is key to this invasion.
Absolutely key. The type B polysaccharide capsule is a crucial virulence factor. It acts like a protective cloak, helping the bacterium evade opsonization.
Opsonization, that's the immune system tagging it for destruction.
Precisely. Without that tag, or with a capsule that prevents the tag from sticking, it's much harder for our body to recognize and eliminate the bacteria. This allows them to cause widespread systemic disease.
That's a fundamental battle, isn't it? Pathogens developing these cloaking devices like capsules. So what about the non-typable strains? They don't have that capsule cloak. How do they cause disease? Different strategy.
They do use a different strategy. Non-typable strains typically cause disease by local invasion of mucosal surfaces, those moist linings of our respiratory tract. For example, otitis media, middle ear infection, happens when these bacteria migrate from the nasopharynx, the back of the nose, up into the middle ear through the eustachian tube.
The plumbing gets infected.
Basically, yes. And in adults with COPD, chronic obstructive pulmonary disease, non-typable strains are a leading cause of those recurrent lower respiratory tract infections, the exacerbations. They manage to persist in the lower airways of these individuals, living both outside and inside host cells.
Inside cells, too. That makes them harder to reach.
It does. And they significantly contribute to the chronic airway inflammation that's a hallmark of COPD. It's also interesting that the specific non-typable strains causing COPD infection seem to differ in their pathogenic potential and even their genome content from those typically causing otitis media.
So they specialize, adapting to different locations.
It seems so. They show clear adaptation to different host environments and disease types.
That's a subtle but important point. And I've heard about biofilms causing problems, like in dental infections. Do biofilms play a role here too?
Yes, absolutely. In the middle ear, for instance, non-typable strains are known to form biofilms.
Like slimy bacterial cities.
That's a great analogy. They're protective communities of bacteria that stick to surfaces. And these biofilms are notoriously more resistant to both our body's natural defenses and to antibiotics compared to free-floating bacteria.
Makes sense. Harder to wipe out a whole city?
Right. Their formation is strongly associated with chronic and recurrent otitis media, making those infections particularly stubborn. Furthermore, H. influenza persists in the respiratory tract and causes infection by cleverly altering the expression of its genes.
How does it do that?
Through sophisticated genetic tricks, things like slip strand misbearing and phase variable expression of DNA methylase genes. These control the expression of multiple virulence genes. It allows for rapid, reversible changes in gene expression, almost like flipping genetic switches on and off.
Wow.
This enables the bacterium to adapt incredibly quickly to different environmental cues and evade our immune responses. It's constantly changing its disguise.
That's incredibly sophisticated for a bacterium. Are we seeing more invasive disease from these non-typable strains now, especially since the Hib vaccine has been so successful?
It appears so. While the overall incidence of invasive disease caused by non-typable strains is still lower than the historical Hib rates, it does seem to be subtly increasing over the past decade or so, particularly in countries with high Hib vaccination coverage.
So they're filling the gap left by Hib.
That's the thinking, yes. As Hib has been largely suppressed by vaccination, non-typable strains might be filling that ecological niche. Most strains causing invasive disease are genetically and phenotypically diverse, which makes them a complex target for management and, future vaccines. It's a dynamic evolutionary process we're watching.
Okay, so what does this all mean for our immune system's fight against H. influenza? And how have vaccines leveraged this understanding?
Well, for the encapsulated Hib strains, the immune response is very clear. Antibody to the capsule is critical for protection.
Antibody to the PRP capsule.
Exactly, the polyribotyl ribose phosphate, or PRP. What's fascinating here is the natural antibody nadir. Babies get some maternal antibody, but the level of this antibody to PRP declines from birth until about 6 months of age.
So they lose their mom's protection.
Right. And in the absence of vaccination, it stays low until around 2 or 3 years old. This age, this dip in antibody levels, correlates precisely with the peak incidence of type B disease. It highlights a critical window of vulnerability for unvaccinated infants.
Oh, that makes sense.
After about age 6, systemic Hib disease becomes unusual, mostly because kids have developed protective antibodies, either from natural exposure to Hib itself, or maybe from exposure to cross-reacting antigens from other bacteria that have similar surface structures.
And this crucial understanding directly led to those super effective conjugate vaccines, right?
Exactly. The conjugate vaccines, where the PRP polysaccharide is chemically linked or conjugated to a protein carrier molecule, they were ingenious.
Why the protein carrier?
Because infants' immune systems don't respond well to polysaccharide antigens alone. But linking it to a protein triggers a much stronger T-cell-dependent antibody response, even in very young babies. This ability to stimulate an effective antibody response in young children was transformative. It effectively prevents invasive Hib infections.
Okay. And for the non-typable strains, no capsule, so what does the immune system target?
Right. Since they lack a capsule, the immune response is directed at their non-capsular antigens, mostly surface proteins. These proteins have generated considerable interest as potential vaccine components.
Okay.
But the human immune response to non-typable strains appears to be more strain-specific.
Meaning immunity to one strain doesn't protect against others.
Largely, yes. This likely contributes to why these strains can cause recurrent otitis media and recurrent exacerbations of chronic bronchitis, even in people with healthy immune systems. It's like fighting off one variant, only for a slightly different one to come along.
So the body can build immunity, but it's a very narrow immunity. That's a key insight into why they persist. Okay, let's delve into the actual clinical manifestations. How do these diverse Haemophilus influenza infections actually present in patients?
Yeah, the clinical picture is quite diverse, varying significantly between the encapsulated Hib and the non-typable strains. For Hib infections, the most serious manifestation, and historically a really devastating one, is meningitis.
Brain infection.
Infection of the membrane surrounding the brain and spinal cord, yes. It primarily affects children under 2. The symptoms are similar to other bacterial meningitis. Fever, altered mental state are common. Neutral rigidity, a stiff neck might be present, but it's variable, especially in very young infants.
Are there common complications with Hib meningitis?
Yes, a common one is subdural effusion. That's a collection of fluid between the brain and its outer membrane. You'd suspect this if an infant has seizures, develops weakness on one side of the body, hemiparesis, or remains unusually sleepy or unresponsive, obtunded, even after a few days of appropriate antibiotic therapy.
And the outcomes?
Even with treatment, the mortality rate from Hib meningitis is around 5%, and morbidity is high. Around 6% of survivors suffer permanent sensorineural hearing loss, and maybe a quarter experience partial hearing loss and delayed language development. It underscores the potential for long-term impact.
That's just devastating.
Yeah.
What about epiglottitis? I know that's another really serious condition linked to Hib.
Yes, epiglottitis is absolutely a medical emergency. It's a life-threatening Hib infection involving severe inflammation and swelling of the epiglottis, that little flap at the back of the throat, and the surrounding tissues.
And that swelling can block the airway.
Exactly. It can rapidly lead to acute upper airway obstruction. It has some unique epidemiological features, too. It tends to occur in a slightly older age group than other Hib infections, usually kids between 2 and 7. And remarkably, it's been noted as largely absent among certain indigenous populations like Navajo Native Americans and Alaskan Eskimos. The reasons aren't fully understood.
That's strange.
Isn't it? Symptoms progress incredibly rapidly, from a sore throat and fever to difficulty swallowing, dysphagia, drooling, and signs of impending airway obstruction. It demands immediate medical intervention, and it can also occur, though less commonly, in adults, often with a similarly rapid and severe course.
Scary stuff. Any other notable Hib manifestations we would cover?
Hib can also cause cellulitis, a skin infection, in young children, most commonly on the head or neck, often presenting with a characteristic bluish-red color and a firm, tender swelling. Most of these patients also have bacteremia bacteria in the blood, and about 10% have another focus of infection somewhere else. Hive pneumonia in infants looks clinically similar to other bacterial pneumonias, like pneumococcal pneumonia, but Hib seems more likely to involve the pleura, the lining around the lungs. And then there are less common but still significant invasive conditions: osteomyelitis, bone infection, septic arthritis, joint infection, pericarditis, inflammation of the heart sac, orbital cellulitis, eye socket infection, endophthalmitis, inner eye infection, UTIs, various abscesses, and bacteremia without an identifiable source.
Quite a range. Okay, let's move on to the non-type B encapsulated strains, and then the big one now, the non-typable H influenza. How do their clinical pictures differ?
Right. The non-type B encapsulated strains types A, C, D, E, and F, they're unusual causes of invasive infection. They predominantly present as bacteremia pneumonia, especially in people with underlying medical conditions.
So more opportunistic.
Generally, yes. Interestingly, we have seen an increased frequency of H. influenza type A infections, often caused by specific clonal strains, in indigenous populations of North America. Again, these typically occur in patients with underlying conditions that compromise their immune system or general health.
Okay. And the non-typable strains, what are their calling cards? These are the ones that have really stepped into the spotlight since the head vaccine became widespread.
Precisely. Non-typable H. influenza is now the most common bacterial cause of exacerbations of COPD, those acute worsenings of chronic obstructive pulmonary disease.
What do those exacerbations look like?
They're characterized by increased cough, producing more sputum, and increased shortness of breath. Patients usually have a low-grade fever, and chest x-rays typically don't show infiltrates, making the diagnosis rely heavily on the clinical context and changes from baseline.
Okay. What else do they cause?
They also cause community-acquired bacterial pneumonia in adults, especially those with COPD or AIDS. Clinically, it looks quite similar to other bacterial pneumonias, like those caused by strep pneumonia.
And you mentioned earlier it's a common cause of childhood otitis media. Can you expand on its role in ear infections?
Yes, it's a major player there. Non-typable H. influenza is one of the big three bacterial causes of childhood acute otitis media, AOM, alongside Streptococcus pneumonia and Moraxella catarrhalis.
The usual suspects for ear infections.
Exactly. Infants with AOM are often feverish and irritable, while older kids will complain of ear pain. These infections are frequently preceded by a viral upper respiratory infection, a cold, basically, which seems to set the stage for the bacteria to move in.
How is AOM diagnosed?
Diagnosis is usually made by pneumatic otoscopy. The doctor uses an otoscope with a small puff of air to check the eardrum's movement. If it doesn't move well, it suggests fluid behind it. Getting an etiologic diagnosis, knowing exactly which bacterium is causing it, requires tympanocentesis, putting a needle through the eardrum to get fluid for culture. But that's not routinely done.
Right, too invasive for most cases. Are there clues that might suggest H. influenza is the culprit in AOM?
Yes, some clinical features are more associated with H. influenza AOM. Things like a history of recurrent ear infections, previous treatment failure, having conjunctivitis, pink eye at the same time, having infections in both ears, or having had recent antibiotic therapy.
And the pneumococcal conjugate vaccines, the PCVs, they've had an interesting knock-on effect here, haven't they?
They absolutely have. The increasing use of PCVs has led to an overall decrease in otitis media caused by strep pneumo. That's the good news. However, as a consequence, there's been a relative increase in the proportion of AOM cases caused by H. influenza, especially in kids who fail initial antibiotic therapy or have recurrent episodes.
So suppressing one bug allows another to flourish, relatively speaking.
It's that ecological shift again. It really underscores the dynamic nature of these bacterial populations and why we need continued monitoring of otitis media causes in this vaccinated era.
Beyond the respiratory tract and ears, what other infections do these versatile non-typable strains cause? It sounds like they get around.
They are surprisingly versatile, yes. Non-typable H. influenza can cause puerperal sepsis, a serious infection in mothers after childbirth, and it's an important cause of neonatal bacteremia in newborns.
Wow, affecting moms and newborns.
Yes, and the specific non-typable strains involved in these maternal and neonatal infections have even been provisionally named Haemophilus quintini. They seem closely related to H. hemolyticus, tend to be biotype IV, and cause invasive disease after colonizing the female genital tract.
Interesting specialization. What else?
They also commonly cause sinusitis in both adults and children, and they're a less common but increasingly recognized cause of a really wide and expanding list of invasive infections. Things like bacteremia, empyema, pus in the chest cavity, adult epiglottitis, pericarditis, cellulitis, septic arthritis, osteomyelitis, endocarditis, cholecystitis, gallbladder infection, intra-abdominal infections, UTIs, mastoiditis, earbone infection, and even aortic graft infection.
That's a huge list.
It is. In countries with widespread Hib vaccines, most H. influenzae invasive infections are now caused by these non-typable strains, and an increased incidence has definitely been observed. Many patients with non-typable H. influenza bacteremia have underlying conditions, HIV, cardiopulmonary disease, alcoholism, cancer, highlighting their opportunistic nature in people with weakened defenses.
That's a surprisingly broad range of trouble for something often thought of as just a mucosal pathogen.
Yeah.
So how do we actually diagnose these infections? What's the detective work in the lab?
Well, for invasive H. influenza infections, the most reliable method is still recovery of the organism by culture from a normally sterile body site, blood, CSF, joint fluid. That's the gold standard for a definitive diagnosis.
Okay, straightforward for invasive disease. But what about from the respiratory tract? That sounds harder.
It is. Diagnosing H. influenza isolated from the respiratory tract is particularly challenging because you have to distinguish it from the complex normal flora that lives there and from other Haemophilus species that are often just harmless commensals.
Right, like the Haemophilus hemolyticus you mentioned earlier. How do we tell those two apart, especially if hemolyticus doesn't always hemolyze?
Yeah, that's where the detective work gets more nuanced and where traditional methods have had to evolve. H. hemolyticus was classically distinguished by its ability to cause hemolysis breaking down red blood cells on horse blood agar. You'd see a clear zone around the colonies.
Or not always anymore.
Exactly. A significant proportion of H. hemolyticus isolates are now recognized as non-hemolytic, which really complicates that classic method. So now, labs increasingly rely on molecular analysis of various genotypic markers, specific DNA sequences, things like 16S ribosomal RNA sequences, or genes for enzymes like superoxide dismutase, or outer membrane proteins like P6 or protein D or fuculose kinase. These molecular targets help accurately distinguish the species.
Using DNA fingerprinting, essentially.
Pretty much. And what's truly fascinating scientifically is that all this whole genome sequencing data we're getting is revealing incredibly complex genomic relationships. It suggests almost a genetic continuum between some Haemophilus species.
A continuum, not distinct species.
The lines are getting blurrier. Their genetic makeup isn't always neatly separated into distinct species boxes. It's forcing microbiologists to rethink some traditional classifications.
That really changes things.
Yeah.
Okay, for head meningitis, what are the specifics for diagnosis? Early detection is so critical there.
Absolutely. For hip meningitis, seeing those characteristic gram-negative coccobacilli in a gram stain of the cerebrospinal fluid, CSF, is strong presumptive evidence. Recovery of the organism from CSF culture confirms it. Similarly, culturing it from other normally sterile fluids, blood, joint fluid, pleural fluid, pericardial fluid, confirms other invasive infections.
Are there faster tests for head?
Yes, an important adjunct to culture, especially for rapid diagnosis of Heb meningitis, is detecting its capsular polysaccharide, the PRP antigen. There are several techniques: immunoelectrophoresis, latex agglutination, co-agglutination, ELISA. These tests detect the PRP antigen itself.
And that helps even if antibiotics were started.
Exactly. These antigen tests are particularly helpful when patients have already received antimicrobial therapy before the samples were collected. Prior antibiotics often lead to negative cultures, even if the infection is still present. So antigen detection can still confirm the etiology even when the bug won't grow.
Very useful. And for the non-typable strains, given their mucosal pathogens, is diagnosis even more challenging? How do you distinguish them from the normal background noise?
Yes, significantly more challenging. Because non-typable H. influenza is primarily a mucosal pathogen and a common part of the normal mixed flora in the respiratory tract, nailing down an etiologic diagnosis from those sites is difficult.
And so how do you make the call?
Well, infection is strongly suggested if you see a predominance of gram-negative coccobacilli mixed with abundant polymorphonuclear leukocytes, those are neutrophils, a type of white blood cell signaling infection in a gram-stained sputum sample from someone suspected of having pneumonia.
Looking for lots of bugs and lots of inflammation.
Basically, yes. But while bacteremia can happen in a small proportion of patients with non-typable H. influenza pneumonia, most patients actually have negative blood cultures. The infection stays localized.
Okay.
For otitis media, as we said, diagnosis relies on pneumatic otoscopy to see fluid. An etiologic diagnosis needs tympanocentesis, which isn't routine. Similarly, figuring out the specific cause of sinusitis also requires an invasive procedure, like a sinus puncture. So treatment for both AOM and sinusitis is often empirical.
Empirical meaning based on the most likely culprits rather than a definitive lab result?
Exactly, based on clinical symptoms and an educated guess about the likely pathogens involved.
So in many cases, especially for these common mucosal infections, we're treating empirically. That brings us neatly to treatment. How do we tailor the approaches for Haemophilus influenza?
Right. For Hib meningitis, the initial therapy should be a potent third-generation cephalosporin, specifically ceftriaxone or cefotaxime, given intravenously. These are broad-spectrum antibiotics that get into the central nervous system really well.
How long is the treatment?
The duration typically ranges from 1 to 2 months, depending on how the patient responds clinically.
And what about managing the complications, especially hearing loss in meningitis? I think I read something about glucocorticoids, steroids.
Yes, that's a critical point for minimizing long-term problems. Giving glucocorticoids like dexamethasone to patients with Hib meningitis significantly reduces the incidence of neurological sequelae, particularly hearing loss.
How do they help?
The thinking is that these steroids reduce the intense inflammation caused by bacterial cell wall components when the bacteria are killed off by the antibiotics. So less inflammation, less damage.
Makes sense.
For this reason, glucocorticoids are recommended as adjunct therapy for children over 2 months old with Hib meningitis. They should be given just before or at the same time as the first dose of antibiotics.
Okay. And other invasive Hib infections like epiglottitis.
Other invasive Hib infections besides meningitis are generally treated with the same potent intravenous antibiotics. For epiglottitis, which is that life-threatening emergency, the absolute priority is maintaining an open airway, often requiring intubation, alongside the antibiotic therapy. Duration is usually 1 to 2 weeks based on clinical response.
So for encapsulated Hib, it's potent IV antibiotics, sometimes steroids. What about the non-typable H influenza infections? Those are often less severe, but maybe more common in settings like COPD.
Right. Many infections caused by non-typable strains like otitis media, sinusitis, and COPD exacerbations can often be treated effectively with oral antimicrobial agents. But there's a significant challenge with ampicillin resistance.
Oh, the lactamase issue.
Exactly. Roughly 20-35% of non-typable strains produce an enzyme called lactamase. This enzyme inactivates ampicillin and related antibiotics like amoxicillin, making those strains resistant. The exact percentage varies geographically.
So amoxicillin alone might not cut it a fair amount of the time. What are the go-to agents then?
Several agents have excellent activity against non-typable H influenza, including the bulk lactamase producers. These include amoxicillin clavulanic acid, that's augmentin, where the clavulanic acid inhibits the buctamate.
Protects the amoxicillin.
Right. Also, various extended spectrum cephalosporins, the macrolides like azithromycin and clarithromycin, and fluoroquinolones.
Fluoroquinolones. Like Cipro?
Ciprofloxacin, levofloxacin, moxifloxacin, yes. They are highly active against H influenza and are particularly useful in adults with COPD exacerbations because they penetrate well into respiratory tissues. However, there's a really crucial caveat here.
What's that?
Fluoroquinolones are generally not recommended for treating children or pregnant women due to possible adverse effects on developing articular cartilage. It really highlights the importance of tailoring treatment choices to different patient populations.
That's a very important distinction. Are there other ways H. influenza becomes resistant besides making lactamase?
Yes, there is another, more subtle mechanism of ampicillin resistance. It involves alteration of penicillin-binding proteins, or PBPs. These are the bacterial enzymes that lactam antibiotics normally target.
So they change the target itself.
Exactly. Strains with this mechanism are known as alactamase-negative ampicillin-resistant strains, sometimes called BLNAR. While they are still relatively rare in the United States, they are actually common in Japan and seem to be increasing in prevalence in Europe. It indicates a potential global spread of this resistance mechanism.
Another resistance mechanism to watch out for.
Definitely. And furthermore, resistance to macrolides is also being seen with increasing frequency globally. All of this just underscores the critical importance of continued vigilant monitoring of antimicrobial susceptibility patterns for H. influenza. We need to ensure our empirical treatment guidelines stay effective.
This brings us to prevention, which, as you said, is a true public health triumph, especially with the Hib vaccine. It's such a great example of how science can genuinely change lives on a massive scale.
It really is. It's one of the greatest success stories in vaccinology. A testament to how understanding bacterial virulence can lead directly to profound public health interventions. There are 3 conjugate vaccines licensed in the U.S. that effectively prevent invasive Hib infections in infants and children.
And they work incredibly well.
They do, and they're remarkable because they don't just elicit protective antibodies in the vaccinated person, they also significantly reduce the rates of pharyngeal colonization with Hib.
So less of it is carried around in the community.
Exactly. This reduction in carriage leads to herd immunity, meaning less spread of the bacterium overall, which further amplifies the public health benefit. Widespread use has dramatically reduced Hib disease in developed countries, shifting it from a common cause of meningitis to a genuinely rare event.
Is it cost-effective? Vaccines can be expensive.
Yes, even with high manufacturing costs, Hib vaccination is remarkably cost-effective because it prevents severe disease and all the associated long-term morbidity and healthcare costs.
That's great. What about global efforts to get these vaccines to everyone? Is the success story the same everywhere?
Sadly, no. The success isn't uniform globally. The Global Alliance for Vaccines and Immunizations, GAVI, has recognized the underuse of Hib conjugate vaccines in many parts of the world. We've seen significant reductions in disease burden in developing countries that have implemented routine vaccination, like the Gambia and Chile, which demonstrates its global potential.
So what's the holdup in other places?
A major obstacle is often the lack of robust epidemiological data on the true burden of Hib disease in many developing countries. Without solid local data, it can be difficult for these countries to prioritize and implement national vaccine programs effectively, especially with limited resources.
Data drives policy. Makes sense. What's the typical immunization schedule?
Generally, all children should be immunized with an Hib conjugate vaccine. The first dose is usually given around 2 months of age, the rest of the primary series between 2 and 6 months, and then a booster dose is recommended at 12-15 months. Specific recommendations can vary slightly by country, so referring to national guidelines like those from the American Academy of Pediatrics in the U.S. is essential.
Okay. What about vaccines for non-typable H influenza? We've talked about their increasing importance in things like otitis media and COPD. Is anything available or coming soon?
Yeah, that's the next frontier. Currently, there are no specific vaccines widely available just for preventing disease caused by non-typable H influenza. But the research and development pipeline is active.
What's being worked on?
Well, there's a vaccine licensed in other countries and used widely globally that contains protein D. That's a surface protein of H influenza conjugated to pneumococcal polysaccharides. This vaccine has actually shown partial efficacy in preventing H influenza otitis media in clinical trials.
Partial efficacy. So, start.
A promising start, yes. And furthermore, vaccine formulations that include other surface protein antigens from non-typable H influenza are currently in clinical trials. There's anticipated progress in developing broader vaccines against these strains. It's a complex challenge because of their genetic diversity, as we discussed, but it's an area of really active and important research.
Good to know progress is being made. What about chemoprophylaxis, using antibiotics preventatively? Is that done for H influenza?
Yes, chemoprophylaxis is an important strategy, but specifically for close contacts of patients with invasive Hib disease. The risk of secondary invasive disease is significantly higher among household contacts.
So if someone in the house gets Hib meningitis?
Then all children and adults except pregnant women in that household should receive prophylaxis with oral rifampin if there is also at least one incompletely immunized contact under 4 years of age in the household.
Okay, specific criteria there.
Very specific. Rifampin works by eradicating colonization of Hib from the nasopharynx, stopping the spread. In childcare settings where an index case has occurred, rifampin might be indicated for all attendees and personnel under similar rules, especially if it's a small group with close contact. But it's generally not indicated for contacts of just a single isolated index case in a larger nursery or childcare setting if the risk of transmission isn't deemed high. Again, specific recommendations should be checked with public health authorities or guidelines like the AAP's Red Book.
Okay, shifting gears now. Let's turn our attention to Haemophilus ducreyi. This one might not be as widely recognized as H influenza, but it's critically important, especially given its role in the global health landscape, right?
That's absolutely right. Haemophilus ducreyi is the bacterium that causes chancroid. That's a sexually transmitted infection characterized by painful genital ulceration and inguinal adenitis, the painful swelling of lymph nodes in the groin.
Painful ulcers and swollen nodes.
Yes. And what's particularly critical here, a major public health concern, is its strong association with HIV infection.
How are they linked?
The open genital ulcerations caused by chancroid significantly compromise the skin and mucosal barriers. This basically facilitates HIV transmission and dramatically increases a person's susceptibility to acquiring HIV if they're exposed. It acts as a potent cofactor in the spread of HIV.
So it's not just a problem on its own. It can pave the way for HIV. I also saw a note in the outline about non-sexually transmitted cutaneous ulcers. That sounds different. Is that a newer finding?
It is, relatively speaking, and it highlights the evolving understanding of this pathogen's versatility. Beyond its well-known role as an STI, H. ducreyi has also emerged as an important cause of non-sexually transmitted cutaneous ulcers, especially in children in certain developing countries.
So skin ulcers, not necessarily genital, and not from sex.
Exactly. This adds another layer of complexity to its epidemiology and underscores that it's not solely confined to sexual transmission routes.
Interesting. Okay, moving into its microbiology, what defines H. ducreyi? What's it like?
H. ducreyi is described as a highly fastidious coccobacillary gram-negative bacterium. Fastidious means it's picky, has complex nutritional needs, and is difficult to grow in the lab.
Coccobacillary.
Yeah,
Short rods again.
short, plump rods or ovoid shapes, yes. And like some other Haemophilus species, its growth specifically requires X factor, or hemin.
Needs factor X, like H. influenza. So it is a Haemophilus.
Well, despite that shared growth requirement and its current classification within the Haemophilus genus, DNA homology studies and chemotaxonomic studies looking at genetic similarity and chemical makeup have actually established substantial differences between H. ducreyi and other Haemophilus species.
So genetically, it's kind of an outlier.
It seems so. Because of this, taxonomic reclassification of the organism is actually quite likely in the future. It just awaits further study and scientific consensus. It's in a bit of a taxonomic limbo right now.
Fascinating. What about immunity? If you get chancroid, are you protected afterwards?
That's another important point. Immunologically, the ulcers it causes contain mostly T cells. But critically, infection does not seem to confer protection. Patients who've had chancroid can and do experience repeated infections. It indicates a lack of durable protective immunity.
No lasting immunity. That's a challenge for control, making reinfection a constant risk.
What about its epidemiology? How common is it? Is it widespread, or are we seeing shifts?
Well, the prevalence of chancroid has actually steadily declined in the United States and worldwide over the past 15 years or so. That's largely thanks to improved STI control programs.
That's good news.
It is. However, it remains more common in certain developing countries, particularly in parts of Africa and Asia. Transmission is predominantly heterosexual, and historically, cases in males have outnumbered females by significant ratios, sometimes 3.1, even up to 25.1 during outbreaks.
Why such a big difference between men and women? That disparity is often attributed to patterns of sexual networks, potentially more frequent seeking of care by men due to painful symptoms, and possibly detection biases as well. Strong risk factors include contact with commercial sex workers and illicit drug use, which often correlate with higher risk sexual behaviors. In developed countries now, most cases are sporadic, often linked to international travel or specific high-risk networks.
And those non-sexually transmitted cutaneous ulcers, where are those typically seen? And are they caused by the same strains as the STI?
Right. As I mentioned, H. ducreyi has emerged as a major cause of these skin ulcers in children in developing countries, particularly in the South Pacific and parts of Africa. What's fascinating microbiologically is that the strains causing these non-STI cutaneous ulcers have genome sequences that are nearly identical to the class I strains of H. ducreyi that cause the genital ulcers.
Wow, genetically the same, but causing different types of sores.
It suggests a common genetic origin, yes, implying a single pathogen capable of causing diverse diseases, likely depending on the mode of transmission, and perhaps host factors we don't fully understand yet.
Let's talk about the clinical manifestations then. What does a typical chancroid infection look like? How does it progress?
Okay, so infection is typically acquired through a break in the skin or the mucosal lining, often just a microscopic tear, during sexual contact with an infected person. After an incubation period, usually around 4 to 7 days, the initial lesion appears. It starts as a small red papule with some redness around it.
A little bump.
Yeah. Then, over 2 or 3 days, this papule evolves into a pustule, like a small blister with pus, which then spontaneously ruptures to form a sharply circumscribed ulcer.
And what are the key features of that ulcer?
Crucially, these ulcers are generally not indurated. That means they're soft to the touch, not hardened like, say, a primary syphilis chancre often is. They're typically quite painful, they tend to bleed easily if touched, and there's usually little or no inflammation of the surrounding skin. Those features help distinguish them clinically.
Painful, soft, bleeding ulcer.
Got it. And what about the lymph node involvement? You mentioned the buboes.
Right, the buboes. About half of patients, often within a week or two after the ulcer appears, develop enlarged, tender inguinal lymph nodes in the groin. These can be quite noticeable and exquisitely painful.
Buboes, like in bubonic plague.
Same term, yes, meaning a swollen lymph node, but obviously a very different cause here.
Huh.
These chancroid buboes frequently become fluctuant, meaning they feel fluid-filled or boggy to the touch, and they can even spontaneously rupture, draining pus. Patients usually seek medical care after maybe 1 to 3 weeks of these painful symptoms. The pain is often what brings them in. So it sounds pretty distinctive overall. But are there atypical ways it can present or other conditions that might get confused with that could complicate diagnosis?
Yes, definitely. The presentation isn't always textbook, which makes clinical diagnosis tricky sometimes. Multiple ulcers can merge together to form giant ulcers, which are much larger and more extensive.
Okay.
Sometimes the ulcers might appear and then resolve on their own, only for the inguinal adenitis, the bubo, to develop and maybe suppurate 1 to 3 weeks later. This clinical picture could be confused with lymphogranuloma venereum or LGV, another STI that primarily causes lymph node swelling.
Right.
And occasionally, multiple small ulcers can even resemble folliculitis, just inflammation of hair follicles. So for differential diagnosis, it's crucial to consider other infections that cause genital ulcers. The main ones are primary syphilis, secondary syphilis, especially the lesions called condyloma latum, genital herpes, and don venosus.
Lots to roll out.
Yes, and rarely, chancroid lesions can get secondarily infected with other bacteria, leading to extensive inflammation and tissue destruction, which can kind of obscure the original H. ducreyi infection.
And those non-sexually transmitted skin ulcers, do they also present diagnostic challenges?
They certainly do. The cutaneous ulcers caused by H. ducreyi can closely resemble those of yaws, which is a non-venereal treponemal infection caused by a subspecies of the syphilis bacterium, Treponema pallidum pertinu.
So they look like yaws sores.
They can, yeah. While there might be some subtle distinguishing features, H. ducreyi ulcers might be less likely to show central granulating tissue or have indurated edges. Our sources state there's substantial overlap in clinical characteristics. This makes clinical differentiation extremely challenging without lab confirmation. And crucially, a serologic test for syphilis, which we use to rule out syphilis, does not distinguish cutaneous ulcers caused by H. ducreyi from those caused by yaws. That further complicates the picture in areas where both might occur.
That leads us right into diagnosis then. How do we confirm Haemophilus ducreyi infection, especially given all these challenges?
Yeah, given that clinical overlap, clinical diagnosis alone is often inaccurate. So laboratory confirmation should always be attempted in suspected cases. It's needed for definitive diagnosis and ensuring appropriate treatment.
What's the best lab test?
The most accurate diagnosis relies on culturing H. ducreyi directly from the ulcer or from pus aspirated from a swollen lymph node, a bubo. However, as we discussed, the organism is highly fastidious, really difficult to grow. It requires very specific selective and supplemented media and careful incubation conditions. This really limits its widespread use in many standard clinical labs.
So culture is the gold standard, but technically demanding and maybe not always available. Are there molecular tests like PCR? That seems like it would be easier.
Well, currently, there is no commercially available FDA-approved PCR assay specifically for H. ducreyi. However, specialized labs, those that are CLIA certified, can develop and validate their own in-house PCR assays for research or clinical use. PCR has been successfully used in clinical studies to establish an H. ducreyi etiology, showing its potential utility, but it's not a widely accessible commercial test yet.
Okay, so diagnosis is tough. How is it often made in practice then, given these limitations?
Given the challenges and the need for prompt STI treatment, a probable diagnosis of sexually transmitted chancroid can often be made clinically if 4 criteria are met.
What are they?
1, the presence of 1 or more painful genital ulcers. 2, no evidence of syphilis, confirmed by a negative dark field exam of ulcer fluid or a negative syphilis blood test done at least 7 days after the ulcer appeared. 3, a clinical presentation that looks typical for chancroid. And 4, a negative test for herpes simplex virus from the ulcer.
So basically, if it looks like chancroid and you've ruled out syphilis and herpes.
That's essentially the logic for a probable diagnosis, yes. It emphasizes ruling out the more common causes first.
Okay. What about treatment for Haemophilus ducreyi? Once it's diagnosed, or probably diagnosed, how do we get rid of it?
Treatment regimens for both the genital and the cutaneous infections are quite specific and generally very effective. There are several recommended options.
Such as?
A single 1-gram oral dose of azithromycin is one common choice, or ceftriaxone, given as a single 250 milligram intramuscular shot, or ciprofloxacin, 500 milligrams by mouth, twice a day for 3 days. Or erythromycin base, 500 milligrams by mouth, 3 times a day for 7 days.
Several good options then. What if the patient doesn't get better quickly?
That's important. If a patient doesn't respond promptly to treatment, meaning the ulcers aren't healing, it's crucial to consider testing the isolates, if obtained, for antimicrobial resistance. Resistance can emerge, although it's currently thought to be rare.
And what about patients who also have HIV? Does that complicate treatment?
For patients living with HIV, healing may indeed be slower, and sometimes longer courses of treatment might be necessary because their immune system is compromised. Also, if there's apparent clinical treatment failure in an HIV-positive patient, it might actually reflect a co-infection, especially with herpes simplex virus, rather than specific resistance to the H. ducreyi treatment itself. So that needs careful evaluation.
Good point.
And finally, from a public health standpoint, to stop the spread, any sexual contacts of the patient during the 10 days before their symptoms started should be identified and treated, even if they don't have any symptoms themselves. That's a key strategy for interrupting the chain of transmission.
All right, and now for our third major player in this deep dive, Moraxella catarrhalis. This organism you mentioned has a fascinating history of being kind of underestimated, even misclassified, but it's clearly a force to be reckoned with now, especially in respiratory infections.
Indeed. Its microbiological journey through various classifications is quite telling. Moraxella catarrhalis, or MCAT, is an unencapsulated gram-negative diplococcus.
Unencapsulated. So no protective coat like HIP.
Correct. And diplococcus means it typically appears as pairs of spherical bacteria. Its primary ecological niche is the human respiratory tract, where it often lives as a commensal organism, just part of the normal flora, often harmlessly.
Okay. And its name changed a few times.
It did. Its taxonomic history is quite interesting. It was initially called Micrococcus catarrhalis. Then, back in 1970, its name was changed to Neisseria catarrhalis.
Why Neisseria? Like the gonorrhea and meningitis bugs.
Exactly. That change was made due to phenotypic similarities, how it looked and behaved in the lab compared to other commensal Neisseria species that also live in the throat. But, based on more rigorous analysis of genetic relatedness using DNA techniques, Moraxella catarrhalis is now the widely accepted name. It reflects more accurate genetic classification. It's a great example of how our understanding of microbial relationships evolves as science advances.
So, it went through a few identity changes. What about its epidemiology? Where do we typically find it? Who gets colonized?
Well, nasopharyngeal colonization, having it live in the back of your nose and throat, is actually quite common in infancy. Colonization rates reported vary widely, between maybe 33% and even up to 100%, depending on the geographic location and the age of the children studied.
Wow. Potentially everyone is a baby. Why the variation?
Several factors likely play a role, things like living conditions, whether kids attend daycare, where close contact facilitates transmission hygiene practices, household smoking exposure, and possibly even population genetics influencing susceptibility. Interestingly, the prevalence of colonization tends to decrease steadily with age. By adulthood, fewer people are colonized compared to infants.
And we saw how vaccines against one bug can affect others. Did the pneumococcal conjugate vaccines impact Moraxella colonization too, even though they target strep pneumo?
Yes, they certainly did. It's another fascinating example of those ecological niche shifts. The widespread use of PCVs in some countries has led to significant changes in the patterns of nasopharyngeal colonization.
How so?
Specifically, by reducing the prevalence of the vaccine-type strep pneumonia, there's been a relative increase in colonization by the non-vaccine pneumococcal serotypes, but also by non-typable H. influenza and by M. catarrhalis.
So clearing out one competitor allows the others more room to grow.
That seems to be the effect. This phenomenon is sometimes called niche replacement, and these shifts in colonization patterns might, in turn, be altering the distribution of pathogens causing otitis media and sinusitis in children. As one pathogen is suppressed, others may expand to fill that vacated space. It's a constant dynamic interplay in our microbial ecosystem.
That's a great example of unintended consequences, requiring constant surveillance. Okay, so how does Moraxella catarrhalis actually cause infection? What's its pathogenic strategy?
Karen cat causes mucosal infections of the respiratory tract, primarily by contiguous spread, basically migrating from where it's colonizing in the upper airway, the nose or throat, down into the ears, sinuses, or lower airways.
Moving downstream, so to speak.
Right. And often, a preceding viral upper respiratory tract infection, cold, is a common trigger, especially for otitis media. The viral infection can damage the mucosal lining and create an environment that's more conducive to bacterial superinfection.
The virus opens the door for the bacteria.
Often, yes. In the context of COPD exacerbations, it's interesting that the acquisition of new strains of M. catarrhalis seems to be critical for pathogenesis. It's not just having it there chronically, but getting infected with a new strain that often triggers the flare-up. And these strains show substantial genetic diversity and differences in their virulence properties. Some are just better at causing disease than others.
How does it manage to stick around and maybe even invade our cells?
Well, it expresses several adhesin molecules. These have different specificities for various host cell receptors on our respiratory surfaces. These adhesins are like molecular grappling hooks, critical for allowing the bacterium to stick firmly.
Gotta stick to cause trouble.
Exactly. Furthermore, MCAT is capable of invading multiple cell types. Its ability to live intracellularly, inside our cells, particularly perhaps in lymphoid tissue, provides a potential reservoir, a hiding place for persistence, allowing it to evade some immune defenses and maybe even some antibiotics.
Hiding inside cells. Clever.
And like many gram-negative bacteria, MCAT sheds outer membrane vesicles into its surroundings. These tiny blebs pinch off its surface. These vesicles can then be internalized by our host cells and seem to mediate several virulence mechanisms. They can induce inflammation, and crucially, they can deliver hodactomase, the antibiotic-destroying enzyme, into the environment or even into host cells.
Delivering weapons via little packages.
Kind of, and that delivery of alactomase can even promote the survival of co-pathogens in mixed infections, like maybe helping out strep pneumo if it's susceptible to penicillin. So Moraxella can be a cooperative troublemaker.
That's quite sophisticated, helping itself and maybe others too. Let's talk about the clinical picture. What kind of infections does Moraxella catarrhalis primarily cause?
In children, as we've touched on, MCAT predominantly causes mucosal infections when it migrates from the nasopharynx to the middle ear, causing otitis media, or the sinuses, causing sinusitis, and again, often preceded by that viral infection.
How big a player is it in otitis media?
Based on cultures of middle ear fluid obtained by tympanocentesis, MCAT accounts for maybe 15–20% of acute otitis media cases. However, if you use more sensitive molecular tests like PCR, you actually detect MCAT either alone or with other pathogens in a higher proportion, maybe 30–50% of middle ear fluid samples. So it's often there, maybe sometimes as a co-conspirator.
So a significant player, maybe more than culture alone suggests. Can clinicians tell if AOM is caused by Moraxella just by looking?
Clinically, AOM caused by MCAT or non-typable H. influenza tends to be a bit milder than AOM caused by strep pneumo. Usually less fever, maybe a lower prevalence of that really red, bulging eardrum. However, there's substantial overlap in the clinical features. It makes it basically impossible to predict the exact bacterial cause in an individual child just based on symptoms.
So empirical treatment is usually the way to go.
Generally, yes, covering the most likely suspects. MCAT also accounts for about 20% of acute bacterial sinusitis cases in children and a smaller proportion in adults.
Okay. And what about its role in COPD exacerbations? You mentioned it was historically overlooked. Why was that, and where does it stand now?
Yeah, this is a crucial area where our understanding has really evolved. MCAT is now definitively recognized as a common cause of exacerbations in adults with COPD. It was historically overlooked, largely because it was considered just a commensal, part of the normal throat flora.
And it looks like other bugs in the lab.
Exactly. Compounding that, it's easily mistaken for those commensal Neisseria species in cultures of respiratory secretions. This led to misidentification or underreporting for years. However, several independent lines of compelling evidence have now firmly established MCAT as a true pathogen in COPD exacerbations.
What was that evidence that shifted the view from harmless bystander to actual culprit?
The evidence is pretty robust now. It includes things like consistently isolating it from sputum during exacerbations, not just when patients are stable. The strong association between getting an exacerbation and acquiring a new strain of MCAT, seeing elevations of inflammatory markers in the body specifically linked to MCAT infection, and seeing patients develop specific immune responses like antibodies after an MCAT-associated exacerbation, indicating the body recognized and fought it as a pathogen.
Makes a strong case.
It does. All these points really support its pathogenic role. In fact, MCAT is now considered the second most common bacterial cause of COPD exacerbations, right after H. influenza. A big 10-year prospective study found it caused about 10% of all exacerbations linked to new bacterial strain acquisitions.
Second only to H. influenza. That's significant.
Yeah.
Do the symptoms look different if Moraxella is the cause?
Not really. The clinical features of a COPD exacerbation due to MCAT are generally similar to those caused by other bacterial pathogens like H. influenza or S. pneumonia. The cardinal symptoms are that increase in cough, increase in sputum production, sputum becoming more purulent, thicker, colored, and increased dyspnea, shortness of breath, compared to the patient's usual baseline state.
Okay. Are there any more serious, but maybe less common, infections caused by Moraxella catarrhalis?
While it's primarily a mucosal pathogen, pneumonia due to MCAT does occur, though not frequently. It typically happens in the elderly, especially those with underlying cardiopulmonary disease that weakens their respiratory defenses. More invasive infections like bacteremia, endocarditis, neonatal meningitis, septic arthritis, those are definitely rare, but they can happen, particularly in immunocompromised individuals.
So given that it's easily mistaken for normal flora and has this history of shifting identities, how do we accurately diagnose Moraxella catarrhalis?
Well, in cases of otitis media and sinusitis, as we discussed, getting a definitive etiologic diagnosis requires those invasive procedures, tympanocentesis or sinus puncture, which aren't routine. So treatment is usually empirical.
Right. What about in COPD?
For COPD exacerbations, isolating MCAT from an expectorated sputum sample from an adult having symptoms is suggestive, but it's not definitively diagnostic, precisely because it can be present as part of the normal flora, even when someone's stable.
So it's about the clinical context again, and knowing what to look for in the lab.
Precisely. Upon culture, colonies of MCAT do indeed resemble those of the commensal Neisseria found in the airway. That visual similarity partly explains why it was overlooked for so long. However, there are key distinguishing features for skilled microbiologists. After about 48 hours of growth, MCAT colonies often turn pinkish and tend to be larger than Neisseria colonies. Plus, there are various biochemical tests and commercial kits using them that can accurately distinguish MCAT from Neisseria based on their different metabolic activities.
Good tips for the lab folks. What about treatment for Moraxella catarrhalis infections? Is antibiotic resistance a major concern here?
Oh, yes. Antibiotic resistance is definitely a major concern and a really interesting part of the MCAT story. It rapidly acquired lactomases back in the 1970s and 1980s that dramatically changed treatment strategies.
How common is that resistance now?
Since then, the susceptibility patterns have been relatively stable, but now over 90% of M. catarrhalis strains produce oxaltomase. That means they are resistant to amoxicillin.
Over 90%. So amoxicillin alone is almost never the right choice empirically.
Correct. Because of this high prevalence of resistance, otitis media in kids and COPD exacerbations in adults are generally managed empirically with agents active not only against MCAT, but also against S. pneumonia and H. influenza, the other common culprits.
So which antibiotics are effective against it, given that high lactamase rate?
Most strains of MCAT are susceptible to a range of antibiotics that can overcome that lactamase. These include amoxicillin clavulanic acid, augmentin, various extended spectrum cephalosporins, the newer macrolides like azithromycin and clarithromycin, trimethoprim sulfamethoxazole, and the fluoroquinolones.
So still quite a few options.
Yes, but, and this is important, there have been recent reports from several centers, particularly in Asia, showing substantial and concerning resistance emerging to macrolides and fluoroquinolone.
Uh-oh. Resistance to the backup drugs, too.
It seems to be emerging. This indicates potential new waves of resistance, even to our second and third line agents. It really highlights that continued global monitoring of antimicrobial susceptibility patterns for M. catarrhalis will be absolutely critical. We need to ensure effective treatment options remain available. It's a stark reminder that the battle against bacterial evolution is constant and never-ending.
Okay, finally, let's delve into the HACEK group. That's a bit of a mouthful to say, but it represents a critical cluster of bacteria known for a very specific and often quite severe type of infection. What exactly is the HACEK group and why are they important for us to understand?
Yeah, HACEK is an important acronym. It represents 5 genera of bacteria, Haemophilus species, some specific ones, Aggregatibacter, which used to be called Actinobacillus, Cardiobacterium, Eikenella, and Kingella.
HACEK. Got it. What ties them together?
What's fascinating here and clinically relevant are their shared characteristics. They are all fastidious again, picky growers, hard to culture. They are slow growing compared to many other bacteria, and they are all gram-negative bacteria.
Fastidious, slow-growing, gram-negative.
Yeah.
How does that affect lab work?
In the lab, they typically require a specific atmosphere enriched with carbon dioxide to grow well. And they usually don't grow on routine enteric media like McConkey agar, which labs use all the time for other bugs. This means the lab often needs to be specifically alerted if a HACEK organism is suspected, so they use the right conditions and media.
So they're picky eaters in the lab. Where do they normally live in the body, and how do they make that leap to causing serious systemic infections?
These organisms normally reside as commensals harmlessly in the oral cavity. They're part of our normal oral microbiome, often found in dental plaque and little crevices around our gums.
Normal mouth bugs.
Right. However, connecting this to the bigger picture of infectious disease, despite their usually innocuous presence, they are also well known to cause severe systemic infections, particularly bacteremia bacteria getting into the bloodstream and bacterial endocarditis.
Endocarditis infection of the heart valves.
Exactly. And that endocarditis can develop on either native heart valves or on prosthetic artificial valves. The leap from being an oral commensal to a systemic threat often happens when there's a disruption in the oral mucosa, like after a dental procedure, or even just with poor dental hygiene allowing these bacteria to enter the bloodstream.
That's quite a jump from the mouth to the heart valves. What's the actual link between finding a HACEK bug in the blood and having endocarditis? How strong is that association?
Yeah, this raises an important question for clinicians. If HACEK is found in the blood, how likely is endocarditis? Well, a nationwide survey in Denmark found that HAC bacteremia had an overall positive predictive value of about 60% for underlying infective endocarditis.
60%. That's pretty high.
It is. It means if a HACEK organism pops up in a blood culture, there's a good chance the patient also has endocarditis, and you need to look hard for it. However, this association varies significantly depending on the specific organism within the HACEK group.
Also,
For instance, one study found that infective endocarditis was diagnosed in 100% of patients who had Aggregatibacter actinomycetum comitans bacteremia, a near certain link for that one. But for Haemophilus parainfluenza bacteremia, it was 55%. And remarkably, in that same study, 0 patients with Eikenella bacteremia had endocarditis.
wow, 100% for Aggregatibacter, 0% for Eikenella in that study. Huge difference.
It tells us that while we group them together for convenience based on some shared traits, their actual propensity to cause endocarditis once they get into the bloodstream differs quite significantly.
So the individual members have different personalities, so to speak. How prevalent are HACEK organisms as a cause of endocarditis overall? Are they common?
In large series looking at all causes of infective endocarditis, HACEK organisms account for a noticeable but relatively small proportion, somewhere between 0.8% and 6% of all cases. So they're an uncommon but definitely important cause that clinicians need to keep in mind.
Which ones are most often implicated?
The most common HACEK agents involved in endocarditis are typically Aggregatibacter species, certain Haemophilus species like parainfluenza, and Cardiobacterium hominis.
And who typically gets HACEK endocarditis?
Invasive infection from these bacteria typically occurs in patients who already have a history of cardiac valvular disease or who have prosthetic valves. These damaged or artificial surfaces provide a good spot for the bacteria to stick and grow. And often this happens in the setting of a recent dental procedure, which can cause transient bacteremia with oral bugs or maybe a nasopharyngeal infection, providing that portal of entry. The aortic and mitral valves are the ones most commonly affected.
What's the typical clinical course like? Is it a sudden aggressive infection or more sneaky?
Generally, the clinical course of HAC endocarditis tends to be subacute, meaning it develops more slowly and subtly, often over weeks or even months. This can sometimes delay the diagnosis.
Subacute, so not like a raging fever right away.
Often not. This is particularly true with Aggregatibacter or Cardiobacterium species. Patients might experience low-grade fever, fatigue, weight loss, other kind of non-specific symptoms for quite a while. However, Kingella-Kinge endocarditis might present with a more aggressive acute course, looking more like other common forms of endocarditis.
Interesting variation there too. How does it compare to endocarditis caused by more common bugs like staph?
Compared with non-HACEK endocarditis, HAC endocarditis typically occurs in somewhat younger patients on average, and it seems to be more frequently associated with embolic phenomena, vascular complications, and immunologic manifestations.
Embolic phenomena, bits breaking off.
Yes, systemic embolization, where pieces of the infected vegetation break off the heart valve and travel through the bloodstream to other parts of the body, lodging in small vessels. This is a common and serious complication. Its prevalence ranges pretty widely in studies, from maybe 28% up to 71%. It can cause strokes, kidney damage, or block blood flow to limbs.
That sounds really dangerous. Can you see these vegetations on scans?
Yes, on echocardiography, ultrasound of the heart valvular vegetations, those abnormal growths on the valves are seen in a high proportion of patients, up to 85%. Interestingly, there might be some patterns. Aggregatibacter and Haemophilus species seem to cause mitral valve vegetations most often, while Cardiobacterium is more commonly associated with aortic valve vegetations. Subtle clues, but potentially helpful.
Let's shine a spotlight on a couple of the specific HACEK species. Tell us more about the Haemophilus species in this group causing endocarditis.
Right. Within the HAC group, Haemophilus parainfluenza is the most common Haemophilus species isolated from these endocarditis cases. In patients with HAC endocarditis due to Haemophilus, about 60% have been ill for less than 2 months before they present. And a significant chunk, maybe 19% to 50%, develop congestive heart failure because of the valve damage.
What about outcomes?
Older studies reported pretty high mortality rates, sometimes 30–50%. But thankfully, more recent studies have documented much lower mortality, now less than 5%. That's a really positive trend, likely reflecting better diagnostics and more effective antibiotic therapies. And beyond endocarditis, H. parainfluenza can also pop up in other infections, meningitis, various abscesses, brain, dental, pelvic, liver, pneumonia, UTIs, septicemia. It's quite versatile.
Okay. And what about the Aggregatibacter species? You said they are the most common cause of HAC endocarditis.
Yes, Aggregatibacter species seem to be the most frequent culprit overall within the HACE group for endocarditis. The species most often involved are A. actinoencetum comitans, A. aphrophilus, which used to be Haemophilus aphrophilus, and A. paraphrophilus.
And they're linked more to prosthetic valves.
They do seem to be more often associated with prosthetic valve endocarditis compared to the Haemophilus species. That's a really serious complication for patients with artificial heart valves. A. actinomycetum comitans can also be found in soft tissue infections and abscesses, sometimes alongside Actinomyces israeli, another slow-growing oral bug involved in chronic infections.
What's a typical scenario for Aggregatibacter endocarditis?
Typically, patients have underlying periodontal disease, gum disease, or have recently had dental work, usually in the setting of some underlying cardiac valve damage. The disease progression with Aggregatibacter is often insidious, really sneaky. Patients might be sick for several months before a diagnosis is finally made, making it a real diagnostic challenge sometimes. And complications like emboli, congestive heart failure, and kidney problems are frequent, highlighting its systemic impact.
Given their fastidious nature and slow growth, how challenging is the actual diagnosis of these HACE organisms in the lab? What's the detective work involved, and have modern technologies help?
Yeah, when an HACE organism is suspected clinically, it's really crucial to let the microbiology lab know. Give them a heads up. This is because these organisms can be genuinely difficult to grow and identify compared to more common pathogens.
Do cultures take a long time?
They can be slow growers, yes. But most cultures that ultimately yield a HACE organism do actually become positive within the first week, especially now with improved continuous monitoring blood culture systems, like the BACTEC system, which detect bacterial growth much more rapidly. Interestingly, studies haven't really shown that prolonging incubation much beyond the standard 5 to 7 days significantly increases the recovery of clinically significant ACE isolates. That kind of debunks an older practice of holding blood cultures for weeks just in case.
So newer systems help. What about other advanced techniques? Have they made a difference for these elusive bugs?
This is where modern microbiology has really made strides. Polymerase chain reaction, PCR techniques, specifically using things like 16S RNA gene amplification, which targets a universal bacterial gene, can significantly facilitate the diagnosis of HAC infection directly from blood or even from surgically removed cardiac valve tissue. This can be a game changer for getting a fast and accurate diagnosis, especially if traditional cultures are negative or slow.
PCR helps find the DNA even if the bug won't grow easily.
Exactly. And other cutting-edge tools like MALDI-TOF mass spectrometry, matrix-assisted laser desorption, ionization time of flight. This technique can identify bacteria very rapidly based on their unique protein profiles, often directly from colonies on an agar plate. MALDI-TOF can further increase the accuracy and, importantly, the speed of diagnosing HAC infections. This allows for quicker, more precise treatment decisions. These technologies have truly revolutionized how quickly we can identify these tricky pathogens.
So we've identified them hopefully faster now. How do we treat them, and what's the prognosis like for patients with HAC endocarditis?
Right, treatment. Because they grow slowly, standard antimicrobial susceptibility testing, figuring out which antibiotics will work, can sometimes be difficult. And sometimes, block lactamase production, if it's present, might not be readily detected by the standard automated methods.
So resistance could be missed. Which ones tend to be resistant?
Resistance seems to be most commonly noted in the Haemophilus and Aggregatibacter species within the group. This makes choosing the initial empirical therapy important. However, newer testing methods, like e-test methodology, which uses antibiotic gradient strips on an agar plate, can help increase the accuracy of susceptibility testing for these slow growers.
Okay. Which antibiotics are generally reliable?
In recent studies, ceftriaxone, a third-generation cephalosporin, and levofloxacin, a fluoroquinolone, have generally been found to be highly active against virtually all HACEK isolates tested. This makes them reliable choices for treatment in many cases.
That's good news, having some dependable options. And what's the overall outlook for patients? Is recovery tough?
Actually, the news here is quite significant and very positive. The overall prognosis in both native valve and prosthetic valve HAC endocarditis is generally excellent. And it is significantly better than the prognosis in endocarditis caused by many non-HAC pathogens like Staphylococcus or Streptococcus, which often have higher mortality and morbidity rates.
Really, better outcomes than for more common bugs.
Generally speaking, yes, it's very encouraging. It indicates that despite their initial elusive nature and their potential for serious complications like emboli, with proper diagnosis often aided by these newer molecular and mass spec techniques and targeted treatment, patient outcomes are usually very favorable. Early detection really plays a crucial role in achieving this positive prognosis. This deep dive has truly brought to light the intricate worlds of Haemophilus, Moraxella, and the HACE group, hasn't it? We've seen how these seemingly small organisms can lead to really significant health challenges, everything from routine infections like earaches to life-threatening conditions like meningitis and endocarditis. What really stands out to you, thinking about how remarkably adaptable these pathogens are? They're constantly evolving, challenging our medical understanding.
What a journey into the hidden details. It's been absolutely fascinating to peel back the layers. We've gone from historical misidentifications, like Haemophilus influenzae's mistaken identity as the flu bug, all the way to the cutting edge of vaccine development, which has just dramatically reduced huge disease to a true public health miracle. And then there's that ongoing complex battle against antibiotic resistance. That's particularly clear with Moraxella catarrhalis and its widespread lactamase, and now the emerging macrolide resistance you mentioned. It's a constant arms race.
It really is.
The surprising facts about vaccine cross-protection, too, like that meningococcal vaccine may be helping against gonorrhea, that's incredible. Plus, the subtle but absolutely critical differences in diagnosing these fastidious organisms and realizing the crucial role bacteria like non-typable H. influenza and M. catarrhalis play in really common conditions like COPD exacerbations. It just highlights the depth and the dynamic nature of this field. It truly feels like a constant dance between the pathogen and the host, where our understanding have to continually adapt.
So if we connect this to the bigger picture then, given this dynamic nature of bacterial evolution that we've discussed and the constant emergence of resistance we saw it with Molectimuses, BLNAR strains, the increasing macrolide and fluoroquinolone resistance, what might the next decade hold for our ability to manage even common respiratory pathogens? And maybe more importantly, how might our understanding of these classic bacteria we thought we knew need to continue evolving to keep us safe and healthy in what is clearly an ever-changing microbial landscape? It's certainly something that demands continued research, vigilance, and maybe a bit of humility about what we still need to learn.